You know, as I was watching Dana's talk and thinking about how the AR-targeted therapies are sort of a back-to-the-future story, because we're taking something that originally was discovered in 1944 and applying it to the future. If you think back to radium, the Curies discovered radium, and that was the opening of our understanding of the phenomenon of radiation and the use of radium with girls who were painting watch dials with radium to make them glow, of course, was the discovery of cancer as an environmentally induced phenomena. So going on that same theme, I'm going to bring everyone back for a moment to really the basics of prostate cancer and what the problem is and how we leverage that biology and that chemistry to develop novel therapeutics to patients' benefit. So this, as everyone recognizes, is a typical prostate cancer patient with metastatic disease. And it's a bone tropic disease, and that bone tropism ultimately causes some of the most feared complications of cancer, period, including the whole host of side effects that I've listed on the right side of the slide, and death. And of course, these result from the prostate cancer localizing to the bone marrow and inducing bone deposition from a complex set of interactions that the prostate cancer cell has with the cells that essentially regulate, participate, and execute bone metabolism, the osteoclasts and the osteoblasts, interrupting and hijacking those basic communication pathways between all of those cells. And although that's a very deleterious effect on the patient, it's a remarkable susceptibility to treatment, and a lot of treatment opportunities in that biology. And of course, a lot of treatment possibilities in just the basic chemistry of bone deposition. The essence of what makes bone hard is hydroxyapatite, and just to bring everybody back to their high school chemistry and med school basic pathophysiology. Hydroxyapatite is made of phosphate-containing moieties, as well as hydroxyl groups, each of which can be leveraged for therapeutic and imaging use. That phosphate moiety is the basis of a number of different drugs, as well as a number of different imaging modalities. And if you swap out those two hydroxyl groups for 3 F18 molecules, you'll get fluoroapatite, which is why we use fluoride in toothpaste, for example, but also why F18 is a good PET imaging agent. And then finally, you have the calcium moiety, which can be leveraged because all of the earth alkali metals, or the alkali earth metals, which calcium is a member of, are calcium mimetic. That is, they all behave like calcium. And so strontium, which is an alkali earth metal, and radium, which is an alkali earth metal, can be substituted for calcium and be deposited in hydroxyapatite and taken up in all of those sites of metastatic disease. So now, even if you were apart from the world of radio-labeled or radiotherapy therapeutics, that biology has essentially been leveraged to patient benefit already. The Zometa bisphosphonate leverages the phosphate moiety to gain access into the bone matrix, and as well, denosumab, which uses the rank ligand pathway as a means of targeting that bone tumor metabolic pathway, is used to benefit patients. And these are essentially quality of life benefits. These are delaying time to skeletal-related events. But moving into the sort of realm of radiotherapeutics, the first set of radiotherapeutics really was strontium-89, an alkali earth metal, and samarium-153, which, as you can see, is conjugated to a phosphate-containing moiety. And by virtue of these two chemical properties, these drugs are essentially taken up in sites of copious bone deposition, which coincide with the sites of metastatic prostate cancer. Now, if you notice, there are some interesting properties about these older radiopharmaceuticals. The first is their depth of penetration. Both of these are beta-emitting radiopharmaceuticals. The depth of penetration of strontium-89 is 2.4 millimeters, samarium-153 considerably less, and as well, the amount of radiation that's delivered is considerably more with strontium-89 into the marrow cavity, with a much higher amount of radiation that's delivered relative to samarium-153. And so by virtue of these two properties, they have different toxicity profiles. Strontium-89 is somewhat more marotoxic as a result, and samarium-153 somewhat less marotoxic because you're simply delivering less radiation into the interior of the bone at the marrow cavity. Both of these drugs palliate pain, so they're both approved on the basis of improving quality of life for prostate cancer patients, and not just prostate cancer patients, but those who have just generally blastic disease. But both of these come at a cost of marotoxicity. As I just discussed, the marotoxicity is somewhat higher with strontium-89 than with samarium-153. These drugs have been explored in terms of prolonging survival and more traditional cancer-related outcomes than quality of life. So this is the Trapeze trial, a European study in which strontium-89 was tested to see whether it could be combined with docetaxel and improve overall survival. This was a four-arm, relatively complex design in which docetaxel and prednisolone were either combined with Zometa or with strontium-89 or both. And the statistical design was such that the strontium-89 containing arms were compared with the Zometa-containing arms to see if either of these improved overall survival relative to just docetaxel. And as you can see, strontium-89, at least in the dose and schedule as given, did not. Overall survival was not significantly improved. And PFS, although it met statistical significance with a p-value of less than 0.05, you can't really say that the small amount of improvement in PFS here actually translates into what we would think of as a clinically significant benefit for these patients. There was a whole program internationally that was really well underway to begin to test more contemporary beta-emitting radiopharmaceuticals with contemporary chemotherapy in the sense of taxane-based chemotherapy using samarium-153. And all of these studies showed that samarium-153 could be co-administered with docetaxel and could be repetitively dosed, even in patients who had been significantly pre-treated. And all of these studies were really ready to just move from the phase 1-2 setting into the phase 3 setting, ours included, when radium-223 really came into view here and really changed the landscape of the whole field of radiopharmaceuticals. Now, radium-223, as I'm sure that you've heard over the last several years, is unique and distinct from the beta-emitting bone-seeking radiopharmaceuticals in the sense that they emit alpha particles. Alpha particles are very large particles. They actually traverse a very small distance, so about 0.1 millimeter. Remember that strontium-89 was 2.4 millimeters. And so they penetrate very shallowly, shall we say, into the bone marrow and really do spare the bone marrow from significant toxicity. Yet within that very small penetrative distance, they release an enormous amount of energy, such that essentially one particle can induce a double-stranded DNA break. So this is a unique drug in the sense that you can actually see this drug where it's doing its action. So this is an autoradiograph of an animal model with a bone metastasis receiving radium. And you can see these short little tracks of alpha particles that are being emitted from the radium. And even in this dense metastatic site, the marrow cavity is relatively spared the radiation. So these images come from the phase 1 US trial that a colleague of mine, Jorge Carrasquillo of Nuclear Medicine, and I did. And I think that it's interesting because it gives everybody sort of a unique view into what's happening to the radium-223 after it's injected. You know, where does this drug go? So if you notice in the first 10 minutes of treatment after injection, you begin to see this hazy area which is localizing to the area of the small bowel just beneath the duodenum. And over the course of the next hour or so, it begins to coalesce into sort of a bolus of drug, which then coalesces and moves into the transverse colon and down into the rectum, and the patient essentially stools it out at whatever rate they're having bowel movements. And so because it begins to collect in the small bowel within really minutes after injection, the actual amount of circulating radiation in the patient is really quite small because it begins to leave the blood pool relatively quickly. But on the other hand, it remains in the tumor for a week to 2 weeks. So you can see the patient's distribution of disease on this FDG PET. You can see the iliac bone and the scapular lesion over here. And here, this is a 6-day image. You can see that the radiation is still well within those sites of bony disease. Now, the Simcoe Trial was a phase 3 study in which patients who had bone-dominant, castration-resistant symptomatic metastatic disease were randomized on a 2-to-1 basis to either best standard of care with radium-223 or best standard of care and a placebo. These patients did not have visceral metastases, and although the protocol technically specified that patients needed to have received chemotherapy, there was this escape hatch in terms of that they could go on study even without receiving chemotherapy if they were felt to be not chemotherapy candidates, and that ended up being about half of the patients. The results I think everybody has seen in previous presentations, and that is a hazard ratio of 0.7, i.e. an overall survival benefit in which the risk of death was reduced by about 30%. And in addition, this drug also delayed time to first skeletal-related events. And on the basis of really primarily the overall survival, but also cited by the FDA as an important clinical endpoint that was met was the time to delaying first SRE. Now, the toxicity profile for this drug is really pretty remarkable when you look at it. If you just compare for the high-grade toxicities, the placebo arm with the radium arm, for each category, for anemia, for neutropenia, and for thrombocytopenia, these are all quite low. About a 2% rate of grade 3 or 4 neutropenia, a 4% rate of grade 3 or 4 thrombocytopenia. And as we saw in today's presentation, if you look now a year and a half after the last patient received the last dose of radium-223, it looks like there was only one patient in the entire trial who had any durable hematologic toxicity. That was one patient who had aplastic anemia, and that patient had received a considerable amount of chemotherapy in his past and also had been treated with samarium-153. There is essentially no difference in the rate of GI toxicity, which I think is an important thing given that this drug is eliminated through the GI tract, and there was more bone pain in the patients who received the placebo than the patients who received the drug. So it's quite a well-tolerated drug, and essentially the cost to the patient and quality of life is really pretty nominal relative to the benefits of the drug, which is an improvement in overall survival. There are many questions that remain in terms of this drug, and so there's a lot of research that really has to be done in the future going forward. We don't know what the optimal dose and schedule of this drug are, and although the Simcoe trial used a schedule of 6 doses given once a month, and so a total duration of 6 months, we don't know actually that that's the optimal duration of treatment either. Although there is some phase 2 data in terms of this drug as a pain-relieving drug, I would say that the pain scale used in that trial was not one that we would generally consider to be standard today, and also that was using a single treatment of radium-223. We don't know how durable that is over the course of 6 treatments, and so there's much to be explored in terms of the pain endpoint. We don't really know how to identify a responder to this drug as opposed to a progressor. It's not clear at all that PSA really bears much value in terms of recognizing a responder to an interpreter, and that's not surprising given that really this drug may not target the cancer cell itself, but may be irradiating the bone stroma instead. And although bone markers have been suggested as an indicator of treatment effect because alkaline phosphatase, for example, does decline in many of the patients, we don't actually know that decline in bone markers correlates strongly with overall survival or not. We also don't know, because Simcoe did not have any standard imaging, whether imaging improves, gets worse, or does not change in patients who either benefit from the drug or don't. We don't know how to combine this with the other therapies that are in the armamentarium, and we don't know when in the disease course it should optimally be placed. So there are many, many questions that have to be answered about radium-223. But radium-223 still does primarily target the bone. And I think that from an ideal potential, we would really want to get the treatment directly docked onto the cancer cell as opposed to treating the host organ to the primary site of metastatic disease. And so if you wanted to really get your most radiation to the tumor and the least amount of radiation to any normal tissue, you have to look at targeting tumor as opposed to targeting bone. The other thing is that from an imaging standpoint, you'd like to be able to image the disease and accurately detect disease before it begins to impact the surrounding organs. And you can't really do that with any standard imaging technology for bone. So if you think about the treatment opportunities that you would have, if you could identify the cancer cell itself before it manifests as to what we would consider to be now using standard imaging modalities as metastatic disease, then you would have an opportunity before definitive local therapy to identify metastatic disease, to perhaps alter your decision-making as to whether a patient should receive either primary local therapy or systemic therapy or both. Second of all, for the patients, for example, who have had a radical prostatectomy or radiation, now their PSA is rising. If you actually knew where that disease was, it might be useful in terms of making decisions as to whether that patient got salvage local therapies or whether they got systemic therapies up front. And we have a number of potential targets by which we can actually begin to explore these possibilities. One, as Dana had shown, is the androgen receptor. Another is prostate-specific membrane antigen, which really isn't truly prostate-specific, but nonetheless is called such. The third is prostate stem cell antigen, for which we as yet don't have an imaging agent, but it's another prostate cancer-specific molecule that could be used for tumor-targeted either therapy or imaging. The kallikrein family, such as PSA, and really many others that could be and have been studied in prostate cancer. So I'm going to talk a little bit about PSMA because of all of those targets, it's really the most mature right now. PSMA, as most of you probably know, is a transmembrane protein, and it's expressed both in metastatic disease as well as primary disease in both androgen-sensitive prostate cancer and castration-resistant prostate cancer. Its expression appears to increase with downregulation of the AR, and so one would think then that it's enriched actually in the population most in need of PSMA-directed either imaging or treatment. And it's expressed across all phases of the disease. So as a target, it's actually quite appealing. Now, if you look from an imaging perspective at what most standard imaging now, it's not tumor-directed. A standard bone scan is utilizing these phosphate moieties to get it into bone deposition. And you get these gamma images that are planar one-dimensional images in which it's very difficult to actually estimate how much radiation is in these lesions. You can say it's sort of a black blob, but you can't really tell how much radiation is in there and say, well, this is improving or this is getting worse over the course of treatment. Sodium fluoride PET imaging is a much newer form of bone imaging, although sodium fluoride has been approved as a PET imaging agent since the mid-1970s. And with sodium fluoride PET imaging, yes, you can get a much clearer picture of abnormal bone metabolism, and that picture is quantifiable. You can actually measure how much radiation is in these lesions, and you can get very precise geography in terms of where in relation to the normal bone the abnormal uptake is. You can get good anatomic location because you can fuse it to a CT. And you can look at this in 3 dimensions. You can certainly rotate these images and see what's going on, but you're still looking at aberrant bone. You're not looking at cancer. You're looking at the derivative of cancer. On the other hand, if you look at these images, this is a standard technetium bone scan on this patient. You can see he's got some symmetric uptake over here. It looks a little darker than DJD, but you're really not quite sure what's what there. He's got a couple of calvarial metastases and some uptake in the rib, in the pelvis. And again, these are sort of hazy outlines of what might be seen. FDG PET shows you that he's actually got some disease in the appendicular skeleton that's going down into his femora. And it looks a little bit clearer that these lesions over here actually are metabolically active and going up into his humeri. So perhaps this actually is not DJD. You see his rib lesions as well to some degree. Now, if you look at this is a PSMA-directed PET scan using an antibody known as J591, which targets the external domain of PSMA. This is quite a different picture now. So now you can see individual lesions within each of his lumbar vertebral bodies. You can see individual lesions in his pelvis going down into his legs. These shoulder lesions are actually clearly cancer here. This is not DJD. This is, again, you're not looking at reactive bone here. You're targeting the cancer cell itself. And you can see a lot of lesions which simply just are inapparent in the sternum on an individual basis. So you're seeing a lot more detail than you would be with otherwise just bone imaging. These can actually pick up disease that's relatively small, and again, you can quantitate them. This is what this lesion looks like with an FDG PET scan in his lumbar spine, seen on a J591 scan. And you can now really localize this to a specific part of that vertebral body. And again, developing this as an outcome measure, this radiation can be fully quantified. You can put a specific SUV value on it and track that over time and see if that SUV value goes up or down with treatment. And again, it's a separate issue as to whether that up or down motion of the SUVs actually has clinical meaning, but at least you have the technology by which to do that now, which you didn't before. Here's another instance in which PSMA-directed imaging can be useful in diagnosing patients with maybe an equivocal lesion in a single isolated area who otherwise doesn't have metastatic disease. And if you look on a standard CT, there's something there between the aorta and the cava. And you're not quite sure what that is. On an FDG, there's not much there to speak of because it's not particularly metabolically active in terms of glucose metabolism. But on the J591 scan, you can really see that looking quite abnormal, and that was biopsied and was proven to be prostate cancer. So what I'm suggesting here is that this technology has quite a bit of potential to make decisions down the line. And again, those studies need to be done, but at least now we do have the potential to image disease directly and quite clearly and in an anatomically discrete manner. It's certainly worth asking as to whether all of those additional lesions actually do represent disease. I mean, how do you really know that? So we underwent a biopsy program in which we took those patients and began biopsying all these PSMA-directed PET-positive lesions. So this is a data set of 50 patients that we looked at. And what you can see is that we counted up all of the bone lesions in these 50 patients. There are 537 bone lesions. Of those, the one modality that picked those bone lesions up to the greatest extent was the PSMA-directed imaging study. And again, when you compare that to those lesions that were apparent on the PET scan but not the bone scan, there were in excess of 152. And the PET scan versus any other standard imaging modality, there were 102 additional lesions. And when you look at the biopsy data, we biopsied 22 of these patients. You can see that pretty much if you had a J591 positive scan, there were 20 patients, 20 lesions that we biopsied. 17 of these were positive on the biopsy. 3 of these that were positive on the J591 scan had a negative biopsy, but you can see that it's quite likely that you would have disease in those lesions if you were J591 positive than not having disease. Now, J591's been used for therapeutic intent. This is a study that Scott Tagawa, Matt Malowski, and I did looking at therapeutically radiolabeled J591. And you can see that you can make PSA go down with this agent. You can make soft tissue disease regress. But the issue here is one of how much treatment you can actually get into a patient, because you're talking about a dose-limiting toxicity of hematologic toxicity. And so you can really only treat patients with 1 or possibly 2 doses of lutetium radiolabeled J591. So moving into the future, the strategy would be this. And again, this gets back to the idea of personalized medicine. You take the picture of the patient using a tumor-directed tracer, the same tracer that essentially you'll attach the therapy to. So let's take PSMA, for example, the same image that I was just showing you. You see exactly where that patient's disease is after you, just with an imaging tracer. And you look at the patient's disease in relationship to his normal organs and how much tracer is being taken up not only by the disease, but by the normal organs as well. Then you watch that tracer be eliminated by the patient in terms of the pharmacokinetics. You take all of that information, how much of the antibody gets into the disease, how much gets into the normal organs, how much radiation is delivered to each compartment, and then how much of the drug, how quickly the drug is eliminated, and you calculate the dose of therapeutic radiation to be given to the patient on the basis of those highly personalized characteristics. So each patient would get a different dose based on those 3 or 4 parameters, having established what those parameters were with the imaging dose. So that whole concept falls under the category of theranostics. That's really where our field is going right now, and that's where the future stands. So in conclusion, the chemistry and the biology of bone metabolism really can and has been used to develop therapies that prolong survival, that reduce pain, that prevent SREs, really the core things that one looks to for therapy, make patients feel better and make them live longer. But moving into the future, we should get a lot more precise about how we get the radiation to where it should be, keep it away from where it shouldn't be, and give it a dose that's personalized to that patient's own tumor distribution, normal organ uptake, and drug elimination. Thanks very much.